The subject given to me is about neoadjuvant chemotherapy for non-small cell lung cancer. Well, the agenda didn't really mention it as a debate, but perhaps it was intended as a debate. Perhaps it's more of a perspective, a more nuanced way of debating. And so, what I'm going to discuss is, well, what is neoadjuvant chemotherapy or versus induction chemotherapy? It may be a matter of just semantics, but it definitely means one thing, that we are intending to give a preoperative therapy with the intention to proceed to surgery, with definite intention to downsize the disease, induce a local treatment which is effective, and finally, and most importantly, improve progression-free survival and overall survival. Well, this can be achieved with chemotherapy alone, but can also be achieved with CTRT. And when we call out CTRT, it means that we are using two modalities of local treatment than one. And if you look at the evidence, the interpretation of the evidence is very challenging. Why so? Because the definition and the staging of lung cancer has evolved over a period of time. The data actually has an amalgamation of so many different types of patients. The radiotherapy doses used in each studies are different. The type of patients taken in each study is different. Uh, the sequencing of therapy has been different. The size of the studies are different, and sometimes very small to very big. And sometimes the patients have fallen out and the studies have been stopped accruing before they could conclude. So it's quite challenging to interpret the entire evidence behind neoadjuvant CTRT versus chemotherapy. Therefore, uh, we generally see that the staging of non-small cell lung cancer has evolved, and this is what is the current staging is, where we describe stage 3 into not only A and B but also C, where C is definitely going for CTRT and perhaps even stage 3B, and perhaps an induction chemotherapy or chemoradiotherapy is only meant for stage 3A, and maybe a very select group of stage 3B. So the jury is still out. But whatever we practice in the neoadjuvant setting has always been the extension of thought process from the adjuvant setting. As far as neoadjuvant or adjuvant chemotherapy or neoadjuvant chemotherapy is concerned, we have fair amount of evidence that it produces the similar results. The meta-analysis shows that it demonstrates no difference between the two approaches of doing adjuvant chemotherapy, which is well entrenched, well engrossed with us, well entrenched into the clinical practices. So neoadjuvant chemotherapy is a very easy acceptance. Whereas if you look at the guidelines, the ASCO special article, JCO publication 2017, which talks about adjuvant radiation, and if you read the line, in patients with stage 3A and 2 disease, adjuvant radiation therapy is not recommended for routine use. Therefore, now extending the same thought process into the neoadjuvant setting is fraught with some confusion and skepticism. So it does, however, call in for a consult with a radiation oncologist to assess the benefits and risk of an adjuvant radiation therapy. So would be true in the neoadjuvant setting as well. Now, coming to look at the data that we have got almost uh, three randomized control trials, maybe one phase 2 randomized control, but three phase 3 randomized control trials. The foremost is the German study, which was a Lancet Oncology publication. It looked at neoadjuvant chemotherapy versus neoadjuvant CTRT followed by surgery. There was no difference in the progression-free survival, which was the primary endpoint, neither in the overall survival. And if you look at the various time points, the difference between the two groups was negligible. However, it did show that chemoradiotherapy increases the pathological response, decreases mediastinal or has mediastinal downstaging, but however doesn't improve survival. The West Japan Thoracic Oncology Group study, again, it does produces better local control, but there is no improvement in progression-free survival. There is no improvement in overall survival. That was our primary endpoint and the primary aim of providing neoadjuvant radiation therapy. Another study, the French study, the IFCT 0101 study, again, increasing local controls, increasing pathological responses, but no improvement in either progression-free survival or overall survival. And finally, we have the SOC trial, which is the Swiss phase 3 study. Again, in this particular study, the problem in this study was chemotherapy and radiotherapy was given in one after another. It was not neoadjuvant chemoradiotherapy, it was chemotherapy followed by radiation and then trimodality treatment. It concluded that radiotherapy did not add any benefit to induction chemotherapy followed by surgery, and they suggested that one definitive local treatment or modality would be enough. When we fall upon with such confusing data, we fall upon a meta-analysis, which is actually a previous meta-analysis before the SARC trial was published. We see that the published evidence is sparse, but does not support the use of radiation therapy in induction regimes. Perhaps it can actually result into potential disadvantage. So, what is the right approach? Perhaps the right approach is better patient selection, better radiotherapy techniques, improving on radiotherapy doses, better systemic therapy. At least what we have from the definitive radiochemotherapy studies, we know that improving on radiotherapy doses has not resulted into any improvement in progression-free survival and overall survival. I did talk about that most of what we practice in neoadjuvant has come from what we practice in the adjuvant or in the definitive setting. Again, adding cetuximab to chemotherapy has not really resulted in the RTOG 617. We know that pemitrixid cisplatin in the PROCLAIM study perhaps is a better chemotherapy, a lesser toxic therapy to offer with CTRT. What we also know from the EORTC study that trimodality treatment can harm. This study actually randomized patients after chemotherapy to radiation alone versus surgery alone, and surgery or chemotherapy radiation uh, had similar overall survival and progression-free survival. So it did warn us about using trimodality treatment over two modalities of treatment, which can actually hamper survivability. So I think overall it is only about patient selection, which may be the key. We know this from the intergroup 0139 study, which randomized patient to CTRT alone versus CTRT followed by surgery, did show that the addition of surgery didn't really lead on to better survival. But what it did tell us that if you were to go in for a lobectomy alone, perhaps you can give CTRT and get surgery done, but only if you have to have a lobectomy alone. But if you undergo a pneumonectomy, then definitely the survival dips down because overall the toxicity of treatment overrides any amount of benefit coming from a CTRT, especially in the setting of CTRT. Of course, there are newer approaches. I must talk
Manish,
about this. Only one more minute. And
yeah,
next is the conclusion slide.
yeah.
A lot of new studies coming up, and I think we must eye on this that new adjuvant IO drugs, which is looking at major pathological remissions, which is definitely increasing. And this is a new field of research. In this very ESMO meeting, there were studies on this, and I think this is going to be a game changer in the coming years. Therefore, in a locally advanced non-small cell lung cancer, it is very important to have multidisciplinary care. For a minimal single station N2 disease, perhaps induction chemotherapy is followed by response evaluation, followed by surgery is fine. But in a bulky multi-station N2 disease, if you have a poor PS, induction chemotherapy is good enough. But if you have a good PS, perhaps induction chemoradiotherapy, response evaluation, and look out. If you require a pneumonectomy, it is better to go in for a definitive CTRT followed by an IO drug. But in case you are able to get away with a lobectomy, perhaps this is the only approach where CTRT may be advisable. With that, I thank you and